Hello and welcome to the learning modules brought to you by Therapeutic Articulation, the developer of the Mobil-Aider orthopedic device. This learning module will focus on ACL testing. ACL injuries can have a significant physiologic, psychologic, and economic impact on the injured individual. There are over 250,000 ACL injuries per year in the United States. ACL injuries are identified by the mechanism of injury and the symptoms displayed. These can include popping, immediate swelling, or inability to weight bear. In addition, clinical tests can be used to identify ACL injuries. These include the anterior drawer, the Lely, the Lachmans, and the use of arthrometers. Despite the availability of these clinical tests, 74% of acute ACL injuries are misdiagnosed in the emergency department. The anterior drawer is one of the tests used to assess the ACL. The performance of this test involves placing the knee in 90 degrees of flexion, wrapping the hands around the most proximal aspect of the tibia and fibula, such that the index fingers are in contact with the distal hamstrings, and the thumbs are in contact with the most proximal aspect of the anterior joint line. The anterior drawer involves anterior displacing the tibia on the femur, and the metrics for this test are somewhat variable. Although the specificity is rather respectable, the sensitivity is quite poor and extremely variable. Given that this test result is either positive or negative, this polarization of the test results does not really allow for room for a partial injury diagnosis. The causes of a false negative anterior drawer test include hemarthrosis and reactive synovitis that prohibit the knee from being placed into flexion for testing in the first place, a protective knee guarding of the hamstrings that restricts anterior translation, or a posterior horn of the meniscus becoming wedged between the medial femoral condyle and blocking that anterior translation of the tibia. The Lely test, on the other hand, involves placing the patient in a supine position with the knee and hip extended. The clinician puts his or her fist or a foam roll under the proximal third of the tibia, just below the tibial tuberosity. The other hand, in this case the one with the green glove on, exerts a downward or posterior pressure over the anterior distal third of the femur. With an intact ACL, the proximal tibia translates anterior on the femur, and as a result of the lever, the foot comes up off the table. So what is being displayed here is a negative test. If, however, the ACL is not functioning, a positive test would be the failure of the tibia to translate on the femur, and the heel would not rise off the table. This depicts a negative test on the left and a positive test on the right. The metrics for this test, again, display better specificity than sensitivity, unless the individual is under anesthesia, in which the metrics are much better, but that's not always clinically possible, or reasonable for that matter. The classic Lachman's has been known as the gold standard for ACL assessment, but there are significant problems. The Lachman's involves grasping the distal aspect of the thigh with one hand and stabilizing it, and then grasping the most proximal aspect of the tib fib and translating in an anterior direction. Here you see a video of that technique, stabilizing proximal, translating distal. You see an abrupt end field indicating an intact ACL. However, again, the test is either positive or negative and doesn't leave a lot of room for the interpretation of a partial tear of the ACL. Protective muscle guarding of the hamstrings also restrict anterior translation with the Lachmans, just like the anterior drawer. Likewise, the posterior horn of the meniscus can be a problem. But probably even a bigger issue is the mismatch of the size of the clinician's hands and that of the patient's legs. Most clinicians have hands that have a span of about 6 to 8 inches. Yet the circumference of an individual's leg can be anywhere from 18 to 25 inches. That makes it very challenging for an individual to stabilize that proximal thigh while translating the distal tib fib and assessing the amount of anterior movement. Add to that the fact that that movement may only be 5 to 8 millimeters. Right? The ability to quantify that motion is quite challenging. That's where the Mobilator comes in. This allows you to use the same classic Lachman technique, but to quantify the mobility of the joint. Here you see the Mobilator, which has a custom contoured proximal attachment that relieves the patella, a custom contoured distal attachment that conforms to the tibial tuberosity, straps around the thigh and the tibia for stabilization, and the ability to actually quantify or objectify millimeters of translation of the tibia on the femur. Here you see a video of the components of the knee kit of the Mobilator. There's the main device with the dovetailed attachments that identify where the proximal attachment fits in and the distal attachment, the straps that are associated, turning the device on, setting the mode of the device into the A mode for the assessment, placing the person's leg over the bolster for the recommended 30 degrees of knee flexion, and then strapping the device into place. Now the mismatch is no longer an issue. The hand proximally can just simply stabilize by pushing down. You don't have to grasp. And the distal hand can translate anteriorly, the proximal aspect of the tibia. So the Mobilator device takes out the pain points of the hand mismatch, right? The inability to quantify the motions, and the ability to identify the magnitude of the translation from intact all the way through to completely torn. In addition, the ACL can be assessed in prone. The prone Lachman's takes out the issue of grasping the proximal thigh and fighting against gravity to translate the distal aspect of the leg. Here you have several options where the person can be over the edge of a table or with the leg flexed over the clinician's shoulder. And again, the advantages are proximal stabilization, no mismatch issues, the ability to palpate while performing the test, the likelihood of the tibia resting in a posterior translated position where you can get a false positive when a PCL is torn, being in a prone position to relax the hamstrings, and allowing gravity to assist in the performance of the technique. In addition, you can perform the prone Lachman's with the Mobilator. So here you see the positioning with the yellow attachment and the exact same hand placement as in the traditional prone Lachman's test. Here's a video donning that yellow attachment, positioning on the posterior thigh and proximal tibia, and delivering that anterior displacement of the tibia on the femur, being able to quantify that value in tenths of millimeters of motion. So when you add the high specificity of the prone Lachmans with the ability to quantify that motion with the Mobilator, you can see how that can be a very powerful test in assessing the ACL. Studies have been performed on the Mobilator that have assessed the validity as well as the reliability. Bench testing here shows the scatter plot of the Mobilator against a known standard, the Zeiss Smart Zoom microscope. This shows a very high ICC and Pearson correlation. Crobash alpha reliability measurements are also quite respectable at the 0.992 level. And a publication comparing the Mobilator to known values with the radiograph has shown less than a 2% margin of error. These proof of concept publications have been in the International Journal of Sports and Exercise Medicine, as well as the Journal of Sports Rehabilitation.
If you would like more information about the Mobilator, how you can use it to then assess the ACL or to perform joint mobilization techniques, or if you would like to listen to more learning modules, please visit mobilator.com. If you have questions about the device, feel free to email dawn@mobilator.com. Thank you for listening to this learning module.